Welcome to Chapter 10, covering the pelvis. So, the pelvis provides bony attachments for some of our viscera. It provides attachments for muscles of the trunk and lower extremities and creates a passageway for both the GI and genitourinary systems. So, it's an important part of our anatomy to understand. The pelvis includes multiple joints that don't have a great deal of motion but do articulate and contribute to stability. So we have the lumbosacral joint between the lumbar spine and the sacrum, the sacroiliac joint between the sacrum and each of the ilium of the pelvis, and the pubic symphysis where the two pubic bones meet. The sacroiliac joint is the articulation between our sacrum and the ilium, and we have two of those because we have an ilium on each side. And at the sacroiliac joint, we have nutation and counternutation. So nutation is what we call sacral flexion, where the sacral base, which is going to be the top part of the sacrum, rotates anteriorly as the inferior portion rotates posteriorly. And this motion occurs with trunk flexion or hip extension. Counternutation is going to be what we call sacral extension, and that's when the sacral base, which again is that top part of the sacrum, rotates posteriorly as the inferior portion rotates anteriorly. And this counternutation occurs with trunk extension or hip flexion. These are both synovial joints, and they have minimal movement in either direction, but we do need that nutation and counternutation to balance out motions of the pelvis. With nutation, we have this anterior tipping of the sacrum within the pelvis versus anterior pelvic tilt, where the pelvis tilts anteriorly around the sacrum. So we can see that relative to one another, an anterior pelvic tilt creates kind of a counternutation. The opposite is true for counternutation, which is the posterior tipping of the sacrum within the pelvis, and the posterior pelvic tilt, which is posterior tilting of the pelvis around the sacrum. So with a posterior pelvic tilt, we get a relative nutation of the sacrum. This video will not play within the video, but I do encourage you to take that YouTube link at the top and go find it for a good explanation of nutation versus counternutation with anterior and posterior pelvic tilt. I think that this guy gives a great visual of it. The right and left pubic bones join together at the anterior of the pelvis to form the pubic symphysis, which is a cartilaginous joint with a fibrocartilage disc in between. It has minimal motion available, however, movement does increase in women during childbirth at the pubic symphysis. Our lumbosacral joint is where the inferior surface of the fifth lumbar vertebra articulates with the superior surface of the sacrum. Motion here is created from either the spine moving on the pelvis or the pelvis moving on the spine. And we have the greatest amount of movement in flexion and extension. Flexion occurs where the spine moves or flexes on the pelvis or with a posterior pelvic tilt, and extension occurs when the spine extends on the pelvis or with an anterior pelvic tilt. We have the least amount of movement at this joint in rotation. The neutral position of the pelvic girdle is when the iliac crests are level and the ASIS and pubic symphysis fall in the same plane. Deviations from this neutral position result in a non-neutral pelvis, which can give us postural deviations and postural deformities. An anterior pelvic tilt produces an increased lumbar lordosis versus a posterior pelvic tilt produces a decreased lumbar lordosis. So we're going to look at each one of these individually. Our anterior pelvic tilt is where the superior portion of the pelvis tilts anteriorly. So if we think of our pelvis as a bowl, that's where the top of the bowl would pour water out of the front side of our body. When we palpate the pelvis with an anterior pelvic tilt, we would palpate the ASIS anterior to the pubic symphysis and superficial to the anterior inferior spine, the AIIS. Upon palpation, we would also palpate the PSIS deep to the PIIS. With an anterior pelvic tilt, again, we have an increased lumbar lordosis and hip flexion, and this occurs within the sagittal plane about a frontal axis. So we want to look at our hip flexors and our spinal extensors contributing to an anterior pelvic tilt, either with a volitional contraction or we have a postural deformity into an anterior pelvic tilt if we have tightness in those muscles. Comparing that to a posterior pelvic tilt, this is where the superior portion of the pelvis tilts posteriorly. So again, if we imagine our pelvis as a bowl, this is where we would be pouring water out of the backside of that bowl. We have the ASIS posterior to the pubic symphysis. On palpation, we would have the ASIS deep to the AIIS and the PSIS superficial to the PIIS. And again, this is just because of the way that the pelvis is rotated. A posterior pelvic tilt works to decrease lumbar lordosis and increase hip flexion, and this occurs within the sagittal plane about a frontal. It decreases hip flexion. Ignore that one. It a decreased lumbar lordosis and a decreased hip flexion, and it occurs within a sagittal plane about a frontal axis, and this is caused by our hip extensors and spinal flexors activating. And so we can create a posterior pelvic tilt through volitional contraction of those muscles, or we can have a postural deformity of a posterior pelvic tilt with tightness in those muscles. A lateral pelvic tilt is identified by the low side and is most often associated with hip abductor weakness on the stance leg. We talk about the lateral pelvic tilt based on the side that drops, but this isn't the side where weakness is typically occurring. So this is going back to like our Trendelenburg gait. So if I'm walking and I'm standing on my right leg, I would see the left side drop because I have weakness of my right hip abductors. The dropping also serves to alter alignment of the vertebral column. So when I drop on one side, I have asymmetrical iliac crest, PSIS, and ASIS. And so we typically aren't going to see this in a postural deformity as much as a gait deviation. With that lateral pelvic tilt, we see the swing leg dropping. So this results in abduction on the right side, or that swing side. For this picture, that right side is the swing leg. And that causes the stance leg to fall into adduction. So we see adduction of the left hip. The trunk then compensates to go into lateral flexion towards the stance leg in order to maintain an upright trunk and head. And so when we have a lateral pelvic tilt, we see a lot of compensatory motions at different joints of the body. Pelvic elevation is the opposite of a lateral tilt, because where a lateral pelvic tilt is a result of decreased muscular control and the pelvis dropping, pelvic elevation is an intentional action. We can also call it hip hiking, but it happens when one side of the pelvis is elevated by concentric contraction of either the contralateral hip abductors or, more likely, the ipsilateral quadratus lumborum. Pelvic elevation creates adduction of the elevated hip and abduction of the lower hip. Pelvic rotation is named by the side that is forward and happens regularly during normal gait. We identify the rotation by naming the side that is forward, and when we have a pelvic rotation, this causes medial rotation of our opposite hip and lateral rotation of the same hip. So if we want to test this to understand things, stand up at your desk or wherever you're watching this. If you're driving, obviously don't stand up, and you should have watched this lecture while you weren't driving. But you're going to stand up and take a step forward with your right foot, keeping your body facing forward in this stance. You're going to notice that you have right pelvic rotation because the right side is forward. And if you pay attention to your hips, this is going to cause you to be internally rotated at your left hip and externally rotated at your right hip. Lateral pelvic shift is important for ambulation because it allows a shift of the center of gravity over the supporting lower extremity to allow for advancement of the swing leg during gait. Our lateral pelvic shift is also accompanied by the lateral pelvic tilt. We need both of those working together in order to allow for normal gait. Let's take a look at some landmarks of the sacrum. So our sacral promontory is the ridge along the anterior surface of S1. The superior articular surface, which is also the base, is where we articulate with L5. And even though it's at the top, it is called the base. It's probably my least favorite part of the sacrum, and I tell you that to make sure if you have to label this, you do correctly identify the base. The auricular surface, so auricular meaning ear, we can see that on the side there. Those auricular surfaces are kind of ear-shaped, and those articulate with the auricular surface of the ilium. And the irregular shape that they have helps to lock the SI joint into place, limiting mobility and helping to enhance stability. And then the ala of the sacrum are fused transverse processes. Here we have landmarks of the innominate bone. The innominate is going to be one side of the pelvis, and so we can take a look at each of these here. We're going to start at the top with the iliac crest, which makes the superior ridge of the pelvis, and we should all be familiar with that from palpation. Moving around clockwise, we have our PSIS, which is the attachment point for our posterior SI ligaments. Our PIIS is the attachment for our sacrotuberous ligament. Our greater sciatic notch becomes the greater sciatic foramen when it's closed in by the sacrotuberous ligament to allow for passage of our sciatic nerve. Our ischial spine is the attachment for our sacrospinous ligament. The lesser sciatic notch is below that, and then we have our ischial tuberosity, which is the attachment site for our hamstrings and adductor magnus. The obturator foramen is the passageway for blood vessels and nerves going into the lower extremities. Our ischial ramus is the attachment for adductor magnus, obturator externus, and obturator internus. The inferior pubic ramus is the attachment for adductor magnus, adductor brevis, gracilis, and the inferior pubic ligament. Our superior pubic ramus is the attachment for pectineus. Our pubic tubercle is the attachment for our superior pubic and inguinal ligaments. The AIIS is the attachment for rectus femoris. The ASIS is the attachment for our TFL, sartorius, and inguinal ligament. And then our iliac fossa is the attachment for our iliopsoas. And this just gives you another view of the bony landmarks, but I would be able to identify them from either picture, just being familiar with the shape of the pelvis to help identify especially our anterior superior iliac spine, posterior superior iliac spine, anterior inferior iliac spine, and posterior inferior iliac spine. The pelvis is made up of 6 total joints. We've got 3 pelvic articulations, one with the pubic symphysis, and then our 2 sacroiliac joints, and then our 3 articulations with the rest of the body, one at the spine and one at each hip. So we have what would seem to be a lot of movement at the pelvis, but we also need a lot of stability there, especially for our pelvic articulations. The lumbosacral angle is the angle between the superior surface of the sacrum and the horizontal line parallel to the ground. So if we have a line parallel to the ground and then we run a line along the superior articulating surface of the sacrum, we get an angle created there. A normal lumbosacral angle is approximately 40 degrees. We can have an increased angle occur with increased lumbar lordosis, and that can be caused by an anterior pelvic tilt, which can result from tight hip flexors or tight erector spinae muscles. This results in increased shear forces and decreased compressive forces because we have greater potential for sliding off of the sacrum with an increased lumbosacral angle. When we have a decreased angle, it's typically caused by tight hip extensors or tight rectus abdominis and results in a decreased shear forces and increased compressive forces because it's a flatter surface for the body weight to be sitting down on. Because we have so many articulations of the pelvis, there are important ligaments for the pelvis to help keep things stable. Important ones to know include the interosseous SI ligament, which is the deepest, shortest, and strongest, but also not shown here because of its depth. It attaches to the tuberosities of the ilium and the sacrum to help limit forward movement of the sacrum on the ilium. We also have our lumbosacral ligament shown here, which helps to reinforce the lumbosacral joint. And the anterior sacroiliac ligament reinforces the anterior portion of the SIJ. From the posterior side, we have the iliolumbar ligament, which limits excessive rotation of L5 on S1 and anterior movement of L5 on S1. The short posterior SI ligament limits forward movement of the sacrum on the ilium. The long posterior SI ligament serves to limit downward movement of the sacrum on the innominate. And then we have our sacrotuberous and sacrospinous ligaments, which are important there. Our sacrotuberous and sacrospinous ligaments help to close the greater sciatic notch to make it the greater sciatic foramen. The sacrotuberous attaches to the ischial tuberosity to limit nutation, and then sacrospinous, like its name implies, attaches to the ischial spine. We have the superior and inferior pubic ligaments for the pubic symphysis, and these serve to strengthen their respective parts of the joint capsule, and so they just run on the inferior and superior aspect of the pubic symphysis. Force couples create the rotary movement that's needed for pelvic tilts. Our anterior pelvic tilt is created with the force couple of our trunk extensors pulling up and our hip flexors pulling down. We can actively produce an anterior pelvic tilt with coordinated activation of this force couple. So go ahead and stand up and think about contracting your trunk extensors and your hip flexors and anteriorly tilt your pelvis. When we do this, we are actively using the muscles, but if those muscles shorten or tighten in that position, we can have a posture that is stuck in an anterior pelvic tilt. Conversely, a posterior pelvic tilt is actively produced with contraction of the trunk flexors, specifically rectus abdominis, and our hip extensors, including glute max and our hamstrings muscles. And so if you want to go ahead and stand up and try to produce your posterior pelvic tilt through activation of those muscles, you can feel how you have to tighten your abs and squeeze your butt in order to posteriorly tilt your pelvis. But again, if we have shortening or tightening of those muscles, we get a posterior pelvic tilt that is a postural deformity. A lateral pelvic tilt is caused by gravity in a single leg stance unless it is corrected by a force couple. The force couple that's used to maintain a level pelvis are going to be the hip abductors on the weight-bearing side and the quadratus lumborum on the non-weight-bearing side. So if the force couple does not activate in order to maintain a level pelvis, we get the resulting hip adduction on the non-weight-bearing side, hip abduction on the weight-bearing side, and then that compensatory lateral trunk lean towards the weight-bearing side in order to keep the trunk and head upright like we talked about in the previous picture. So we need the force couple of the weight-bearing hip abductors pulling down and the non-weight-bearing quadratus lumborum pulling up in order to maintain a level pelvis. One last slide on back pain associated with the pelvis. It's important to know that back pain tends to be a recurrent or cyclical problem for patients, especially when it's related to posture. And it's also important to remember that the menstrual cycle and pregnancy can cause a resurgence of pain that is short-lived and has no other causal factors. Before you come to class, make sure you understand the force couples responsible for each of the pelvic motions and what is happening at all of the joints when we have pelvic motion. Write down any questions you have and bring them to class so that we can be sure to talk about them as a group.